Hello, good morning.
Good morning, Doctor
How are you? Is this Mohammed Khalil?
Muhammad. Yes,
Mohammed. Okay, how are you, Mohammed?
I'm great. How
Great.
are you?
Fine, fine. I thought that there was another student who was going to join, actually. I'm not sure. Not
Yeah,
sure.
I think so.
Yeah,
The,
okay. All right. Well, I tell you what, I think we can go ahead and get started, actually. So
sure.
now, Mohammed, so let me start off by saying, so Mohammed, where are you from?
I'm from Lebanon, Beirut.
Okay. And where are you now?
Now I'm there. I'm in Beirut. I
Oh, okay.
finished. Yeah,
Okay, wonderful. So then it sounds like you're going to apply for residency pretty soon.
yeah.
Okay.
I'm
All
doing. I couldn't get the visa to come to the States, so I was forced to do telerotations.
right. Of course. Okay. Now, uh, this the rotation is family medicine,
Yeah.
and so and it's virtual.
Mhm.
So when thinking about what are the topics that are best covered, um, because I'm a family physician myself. So I'm a family physician, and I do a lot of obstetrics as well. So
Nice.
what I've learned in terms of the training of becoming a family physician and then practicing is that the medical the clinical knowledge, the medical knowledge is very important. There's no doubt
Yeah.
about it.
Yes.
um, but there's another area that is very important in family medicine, where if we don't if we are not good in this area, then we may not be able to get into family medicine. We may fail during the training process.
Mhm.
And that's the area um, of communication, of awareness of the factors of family health and community health,
Yeah.
working in a team, for example. So communication, working in a team, awareness of the impacts of family and community.
Yeah.
Those are some things where, that awareness and that ability to work and communicate with others, that's very, very critical. Especially if someone is coming from, another country, coming to the United States. And it's easier if you grow up here and you're kind of familiar with some things. But otherwise, you may not know. And in family medicine, those sort of things are very important factors of success. So when thinking about, okay, we have a virtual rotation, let's think about, what can we do?
Yeah.
Basically, I felt that there are four categories, four topics that I felt would be beneficial. Okay, I thought that if we review them, we can have a good, we can have that understanding, so that if you ever are in a
Mm.
family medicine surrounding, you're aware of it. Okay.
Sure. Okay.
So today the topic, if I'm not mistaken, is consultation and team care, I believe, right?
Yes. Yes.
Next time it'll be quality improvement. I'm sorry. Next time it's managing multiple morbidities,
Okay.
and that is how to manage a lot of medical problems. So that's something that we see in the United States, is that patients come in and they have a long list of things that they want addressed. I don't know,
Yeah.
Mohammed, is it the same thing in Lebanon? Is it the same sort of thing?
Yeah, I did some electives here, and yeah, for sure. And family physicians are not super popular here in
Right,
Lebanon. You
yeah,
directly go to a specialist.
right.
So Yeah, now I know that primary care is extremely. By the way, I studied medicine in Poland, not
Oh,
here.
wonderful. Okay.
Yeah, and also in Poland it's different.
Uh-huh.
Yeah, so it's really important to keep up with all the diseases a patient might come present with, as well as all the medications he or she takes to not to order a lot of medications and
Mhm.
just treat them as good as possible before referring them to a specialist.
Very good. Okay. Okay. Yeah. Yeah. And that's interesting. I'm originally from Egypt, and
Okay.
yeah, I think primary, like family medicine, primary care, it's not quite the same in the United
Yeah.
States. So, for example, here in the United States, family medicine is considered a specialty.
Yes.
It's a specialty. You don't quite think of it that way necessarily because outside of the U.S., it's like a GP. Um,
Exactly. Yeah.
yeah, it's like a GP, and it's not really thought of as a specialty. Where here, it's a specialty. Actually, here, GP is something else. Actually,
Mhm.
yeah, yeah,
Oh.
GP is if you finish medical school and then you do 1 year of internship, you're a GP. Okay.
Aha. Okay.
Actually, you need to be a GP in order to complete the residency.
Okay.
Yeah.
Yeah.
So GP is, and really there aren't really GPs nowadays, actually. Um, so it's not, it's a little bit different. So family medicine is additional training in addition to the, that basic level. And it's, the topics that I wanted to mention during our few weeks together is really included in that, because
Okay.
like
Great.
hypertension, diabetes, all these things, like, look, that's something everybody has to read about and become familiar with and get that experience. um,
Mhm.
uh, 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 um, and that's fine, but you'll always be learning in these things. These
Yeah.
things, like, for example, today will be today it's consultation and team care. Like, that's something that you kind of have to have good competency in from the outset. And then again, next week we said we would do managing multiple morbidities. After that is quality improvement. Okay,
Yeah.
that's and that's not something that I felt like I got a lot of training in medical school or
Yeah.
even residency. And then beyond that, it was going to be, I would have to double check. I would have to double check the curriculum I sent
Okay.
out.
Okay.
I think it may have been, I think it was alcohol, actually.
Okay.
Um, Let me see.
That's why in the newest form of Step 2 CK, they increased the number of quality improvement and
Oh,
ethics
really?
and teamwork. Yeah, it was maybe 3 to 4%. Now it's up to 12%.
Oh, wow.
Yeah,
Yeah,
because
yeah.
mm,
Yeah, definitely, definitely. Yeah, it's very yeah, so I will look forward to that one, may be my favorite one, actually. So I'll look forward
yeah,
to that.
okay,
So yeah,
okay,
so that is another way, Mohammed, where this may be beneficial for you. I just want to see, let's see. I just want to see the I think it was alcohol. I want to say it was alcohol, the very last one. So anyway, we'll, we'll come to that. So I would say, Mohammed, let's review, shall we?
the
Let's
cases.
review the topic for today. But do you have any
Okay, sure.
questions on what the goal for the virtual rotation is?
The goal, as you mentioned, yeah, I really liked, and I hope I get the most. As I emailed you, I want to get the most exposure. What is the life of a family physician in the US? So
Right.
if I go, hopefully, I will be ready to any challenges I face.
Okay. Wonderful. All right. Well, let me see if I can pull it up. And you got the thing that I emailed out, it sounds like.
Yeah, I received 3 emails from you, and
Okay.
I did the presentation. Yeah,
Oh, you did the president. Wonderful. Okay, Mohammed, that's
yeah,
very good. That's a medical topic. Like, we should probably do a medical topic, So,
yeah.
let me share the screen and we can go through these cases and talk about it. Give me one
Okay,
moment. Page 15. Okay, I'm going to share my screen, and it should be this one. Okay. All right. Um,
Were you born in the US or
no,
you were
no,
in Egypt?
no. I was born in Egypt, actually. Yeah,
Oh, okay.
there's an area called Beni Suef in Egypt. I was born there.
Ah, I've been to Egypt, to
Oh
Masr
yeah.
al-Jadida, if you know,
Oh
if
sure,
you know
sure.
it.
I mean,
Yeah,
not well, but oh, definitely, definitely been there several times. So that's great. So did you enjoy it?
yeah. I loved it. Yeah,
Yeah, yeah,
we went all the to the touristic places there. It's really nice. The people mostly,
yeah,
they're
yeah,
extremely friendly.
yeah, yeah, yeah. Absolutely. Actually, it's funny. Just recently, I was looking. We started watching. My wife and I, we started watching Temseleyes actually, but
Uh-huh.
Temseleyes, yeah, not Temseleyes recently, but like from maybe 20 years ago. Uh,
Oh,
and yeah, oh Muhammad, these Temseleyes, I have to say, they are excellent, just
really?
excellent. Oh yeah, 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 yeah. I
Maybe
didn't.
send me the name.
Oh yeah, okay. I'll tell you. Oh, I'll tell you too. I'll tell you
Okay.
too. Yeah, actually, because I just finished watching them. Actually, they were temsaleas. When I told my parents, I said, "Oh, hey, I saw some temsaleas. They were excellent." But they were 25 years ago, so maybe my parents knew them. And then I told my parents, they're like, "Oh yeah, yeah, yeah. This is excellent temsalea." I said, "Excellent temsalea. Why didn't I watch it when I was a kid?" So one of them
Yeah.
is لن نعيش في جلباب أبي. It's on YouTube, by the way.
Okay.
Oh
I'll watch it
yeah.
there.
And see, Muhammad, see, that's the thing. I think I think if we grew, I think I grew up without YouTube, and the internet. Actually, the internet didn't come until I was like in college almost. So
Okay.
so yeah, so now with YouTube and all these things, oh, we could watch everything, and
Yeah,
so
you feel connected.
yeah, yeah. So okay, لن نعيش في جلباب أبي. Excellent, excellent.
Okay.
Okay. The other one is دق الشارد.
Do
Okay. دق
الشارد.
دق الشارد. Yeah,
Okay.
yeah.
I'll check them out.
So that one, because I'm originally from Beni Suef. Beni Suef is like the Beled, and
Oh,
yeah, yeah. And actually, I mean, yeah, it's basically the Beled in Egypt, and actually both of them. Now that I think about it, both of them have to do with like coming from the Beled and the customs of the Beled and things like that.
yeah, a lot of, yeah, yeah, yeah.
Yeah, yeah, yeah. So yeah, check them out.
Okay, I will for sure.
All right. So okay, let's take a look here. All right. Let's take a look here, Mohammed, and let's kind of go through. So number one, so this is consultation and team care. Okay. All right. So number one, you are a recently graduated family physician new to a community practice made up of two other physicians. Okay. And
Yeah.
by the way, like here in the US, we talked about the Beled, right?
Hmm.
Well, here, there's also the Beled. I just want to say,
Like
you have,
rural areas?
oh, big time. In the US, yeah.
Okay.
Yeah, there's a
Okay.
lot of that. Uh, so anyway, that's where, it's, you have, the patient population is a little bit different in some ways. So anyway,
Okay.
let's just say, so when you talk about community, this is one of the things to be aware of, are we in a big city or are we in some small rural area where, there's not a lot of health literacy or there's not a lot of resources, things like that. Okay,
Yeah.
you are a recently graduated family physician new to a community practice made up of two other family physicians, a family nurse practitioner and a physician assistant. Okay, so we're talking about team care. So one
Yeah.
thing we're not even finished the question yet, Mohammed, but I want to say that you know there are many disciplines here in the
Hmm.
United States. So In Lebanon, is there something called a nurse practitioner or physician assistant?
Yes. Yeah.
Okay. Can you tell me about it?
A nurse practitioner is just an RN. They work in the hospital, but not in a small clinic. Usually, there's one physician assistant or a lab technician. Usually,
Mhm.
nurses are mostly in the hospital.
Mhm. Yeah,
And
yeah. So these ones, Mohammed, like nurse practitioner here, it's beyond just a nurse. So a nurse
oh,
practitioner is someone who gets additional training and who functions like a physician. They prescribe things, they diagnose, they treat.
oh,
Yeah, believe it or not. Now, their training is not as extensive as a physician, but you see, this is another type. We call it a mid-level provider. Okay,
okay.
that's what we call it, a mid-level provider. So you have physician, and then you have, okay, fine, like a nurse. But then in between, you have other disciplines that can diagnose, treat, manage under the supervision of a physician. So a
Oh, okay.
physician will supervise. It doesn't have to be on-site immediate supervision, but it can at least be indirect supervision. So usually a nurse practitioner and physician assistant is the same kind of thing. A nurse practitioner is someone who is a nurse, but they get additional training. Physician assistant is someone who trains like a physician, but not as much training, and they function under the supervision of a physician. Okay?
Okay. Okay.
So that's what physician assistant is. So you can see there are multiple different levels.
Yeah.
Okay, yeah. So we have, okay, so you're coming and you're joining a group made up of two other family physicians, a family nurse practitioner, which is a mid-level provider that's a nurse, and also a physician assistant, another mid-level provider. So you see you have two physicians, two mid-level providers. Okay, so that's the group that you're there. So they see patients, but they may come to you to ask for advice, and you oversee
Consultation.
their,
Yeah.
oversee their care. Okay.
Mm-hmm. Okay.
All right. So you see a 47-year-old patient for several visits, but are concerned about whether or not he should undergo a cardiac catheterization because of a 2-year history of intermittent but stable chest pain and a strong family history of premature cardiac mortality. Okay.
Yeah.
So you're seeing this patient and you're just worried about his cardiac condition, and you think he needs invasive testing to verify his cardiac status. So number one, which of the following is or are among the factors you will consider in choosing a consultant? Okay, because you're going to refer, right?
Yes.
Okay, that's fine. So you're going to refer. So which of these will be the factors that you will consider when referring? Go ahead and think about it and tell me what you think.
Um, I already went through it,
Good.
and I was thinking the skill is important,
Right.
and
Super important. Yeah.
yeah, geography for the patient is also extremely important, especially in the US, because it's a huge country. You can't send him to another if he can't afford or he cannot because of work or any other reason.
Hmm.
So B as well, and the experience of the practitioner in your practice with the subspecialist.
Right.
Yeah, so maybe E, I thought.
Yeah. E sounds good. Absolutely. Yeah. Yeah. When talking to patients, you would say that, oh yeah, this person that I'm referring to you to, this is someone that I would refer my family to.
Mm,
So then the patient says, oh, okay, this is very
yeah,
good. Geographical convenience is very important as well. Yes. I think sometimes, personally, I feel like this might be an easy one to overlook. But yes, if someone says, I cannot get there easily, then that is a reason to say, okay, if we can't do that, then let's think of some other options. So
mm,
that is definitely true. The experience of other practitioners in your practice, absolutely. It's not just skill and reputation, but your experience with the
yeah,
subspecialist is important, and that's why the subspecialist needs to really value how they interact with you as well.
Yeah.
Um,
Yeah.
and the skill of the consultant is the only important consideration. I mean, no. I mean, it's
Yeah.
basically these other things are
The
critical.
others as well. Yeah.
Yeah, good job. Okay, so next one. After choosing the appropriate consultant, you electronically send her a request. The content should include all of the following except. What would you do?
I would definitely include the history
Mhm.
and the physical exam.
Yeah,
So they will,
that would be good. Yeah.
yeah, they will know everything,
Mhm.
and they don't have to do it all over again.
Right.
And I would say maybe C, like a directive to do catheterization as soon as possible. Maybe this is the answer because they might have another opinion about it. This is why we referred them, right?
Right. Right. Yeah, absolutely. C would be correct. Yeah. So what I like to talk about, Mohammed, is
Mhm.
the etiquettes when dealing with a specialist. Okay, there are
Okay.
some etiquettes or manners to have when working with them. That's what I call it. Now, obviously, when referring, the specialist likes to know that you did everything you could do, because for
Yeah.
the specialist, they are thinking, why are you contacting me? They are very highly trained in this specific area. So for them, they say, well, if you're reaching out to me, then you must be reaching out because the problem is more complex. The problem is not straightforward and easy. This must be something you must be needing a specialist for. So for
Yeah.
example, if someone, you would not, as an extreme example, you would not refer someone with a urinary tract infection to infectious disease, right?
Yeah. 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 Yeah.
That would
Waste of their time.
big waste of time. So
Yeah.
that's right. So the specialist is thinking, okay, this must be worth my time.
Mm.
Okay, that's what they're thinking. So the history and the exam helps to demonstrate that. It helps
Mm.
to demonstrate that, oh, they have done everything that they can, and that is why this is worth my time. If the specialist ever feels that this is not worth their time, you're in trouble. You're in big
Really?
trouble. Yeah. They need to feel like this is worth my time. Okay.
Okay.
And that's why it's important to do everything that you reasonably can. You say, I've done this. Well, now the history and physical
Okay.
begins to do that. And then when you say if we jump to E,
Yeah.
any supportive laboratory data, then that's showing that, look, I have done everything I can. I did this,
Yeah.
I did this, I did this. And then they say, oh, wow, they've ordered all these things, they've done all these things. Clearly, this is worth my time. And the
Yeah.
other thing, Mohammed, is that they don't want to repeat the basic stuff. Like,
For sure. Yeah.
let's say someone says, I have, also just to use the same example, I have burning with
Hello, Dr. Murad.
Oh, hi, good morning. Hello? Hello?
Yeah. We heard you, Khurram.
Hello?
Yes, we can hear you.
Hello, Khurram, are you there? Okay, well, let's allow Khurram a few minutes to get logged on. And so just to complete what we were saying, anyway, I think you got the idea, Mohammed, okay?
Yeah. Yeah. Yeah.
Yeah, and this is not just when you electronically send a request, but also sometimes you're gonna talk to the specialist by the phone. And when you talk to the specialist by the phone, you need to say the history and exam, and
Yes.
it needs to be short, actually. Yeah, you need to say, here's the history, here's what's going on, and maybe 2, 3 points. And then you say the exam, and maybe 2, 3 points. And then
Yeah.
you give the supportive laboratory imaging data, also couple quick points, okay? So you see, you're
Mhm.
talking about 7, 8 points, really.
Yeah,
You're
yeah,
not talking about something, but those 7, 8 points need to include all these things, okay?
yeah.
So then the specialist says, okay, yeah, now what if you, now let's say for example, you do a history and exam, but you don't do anything, okay? You don't order anything, you don't try anything, you do nothing, right?
Yeah,
And then you send the patient over, then the specialist will be like, okay, I see what you're thinking, but why didn't you do this, you know?
yes, yes,
And,
yes.
right. So, and then if we use this example, this is a cardiac catheterization. This is something only a cardiologist does, right?
Yeah,
So that's
exactly.
why
Yeah.
the cardiologist is thinking, oh, you're sending me, it looks like you've done everything you can and you're sending me for this. Okay, this is worth my time. For a cardiologist, they think cardiac catheterization, that is worth my time. Okay?
Mhm.
To
Okay.
counsel a patient on diet and exercise is not worth his time.
Mm,
So,
for sure.
but cardiac
Yeah.
catheterization is.
Hello?
Oh,
Can you hear
hey.
me, Dr. Murad?
Hi, Khorram. How are you? It's okay, Khorram. Do your best. We can
Can you
hear
hear
you.
us? We can
Yeah.
hear you.
Hello?
Hold on. I
I
think.
can't hear you, Dr. Murad.
Okay.
Oh,
There should be a chat function. Hold on. Where's Khorram coming from anyway?
I'm not sure.
Okay. Hold on 1 second. I think there's a chat.
I can't hear you, Dr. Murad.
Hold on. There should be a
Hello?
chat function. We can hear you. We can hear you. Okay.
I can't seem to hear anyone, and it's not muted on my end.
Okay. Yep, we can hear you. Okay. Keep trying. Keep trying. Don't worry. Let's see how it goes. Okay.
Sure, no problem. Yeah, it wouldn't let me join in earlier as well. Kept on saying that you're in another another meeting.
Oh, okay.
I
Okay.
will try to close it and join again.
Okay.
Yes.
That's fine. Don't worry. Okay. Okay. So, all right.
You are really nice.
Let's see. Where were we, Mohammed? Okay. So then this leads us. Actually, we're only on number 2. My goodness, we need to we need to keep going.
Hurry up.
So this leads us to the most important thing about
Yeah.
when you're talking to a specialist. When you are sending a patient to a specialist,
Mhm.
you do a few points, history, exam, and supportive data. Then when you talk to a specialist, Mohammed, you need to have a specific question. Okay.
Okay.
So not only is the specialist thinking, is this worth my time? But they're also thinking, what is your question? Okay.
Yeah.
What a specialist does not want to hear is tell me just tell me what to do.
Yeah. Yeah. Yeah.
Right.
Okay.
They just say, here, this is your problem. Figure it out.
Figure it out.
Yeah, yeah.
Yeah.
They hate that. Okay. They hate
Okay.
that. And if you're a specialist, you'll hate that too. Okay,
Okay.
Khorram, are you in?
I am in. Thank you, Dr. Murad.
Wow, good job, Khorram. See? Well, so what was the issue? I'm curious.
I'm not sure. So I tried to join, and it kept on saying that you're already in a session, and it wouldn't let me join. And then I just closed it and rejoined a few times, and it finally just let me in now.
Okay, very good.
Good.
That's
Good.
fine. Okay, Khorram. So, just to kind of recap, where we're at, we basically talked in the beginning on how, this is a virtual family medicine rotation. So we were in planning for today and the next few weeks, the question was, what would be useful? Okay. Now, I think that, and I'm a family physician, obstetrician myself. Okay.
What's up?
So for me, I think about, okay, what would have been useful for me? What could have I benefited from? What do I think would be from experience helpful for you? So for me, I think, family medicine in the United States, because this is a family medicine, virtual rotation. So family medicine, it's important to have good medical knowledge. I mean, that's clearly important. That's obviously, it goes without saying. But something that is what I have seen to be very critical in family medicine is awareness of some of the family and community impacts on medical care, as well as communication, okay? So my feeling is that if someone is very lacking in awareness of these things, then they will more likely fail from that than they will from lack of medical knowledge. Because lack of medical knowledge, it's not good. Obviously, you want to solidify that as much as possible, but rarely does someone get fired for that. Okay?
Yeah.
Really, people get in trouble where they're not professional, they don't know how to communicate, they are unaware of the family and community health impacts on care. They are unaware of the system in which they're practicing in, and they do things inappropriately because of that. That is where people really get in trouble. And so that's one of the things that distinguishes a family physician from other specialists, is being very good in terms of awareness of those things, okay? So for that reason, I felt that, okay, I mean, we could talk about hypertension, we could talk about all sorts of things, but what might be really useful for you is, especially if it's virtual, actually, is to focus on the topics that I sent out. So basically, the ones that I sent out, like today, it's consultation and team care.
Team care.
Okay, that's what we're going through today. Next week will be quality improvement. Okay. The week after, and quality improvement, by the way, is becoming a more and more important topic in the healthcare system today in the United States. And it's not something that I ever got training in. Like, I never got training on, well, not in medical school or residency, okay? Which is a shame. So I feel that we should talk about that. Also, I would like to, I believe alcohol is the last chapter, actually. So, those are things that I think are worth reviewing for you. So, anyway, I think we also talked about how family medicine is a distinct specialty in the United States. Muharram, where are you coming from? Like, where are you?
Oh, I'm in New Jersey.
Oh, you're in New Jersey. Oh my God. Okay. Well, we're good then. So I don't have to go into, here in the United States kind of stuff. So
no, definitely. And I definitely think communication is important for family medicine. They're like the quarterback for the patient, and they're trying to, like you said, communicate with specialists, try to get the patients their medicine, and arguing with insurance companies and pharmacies. And at least that's what I noticed in my family medicine rotation, like fighting for the patient to get the insulin they deserve, trying to write letters to cardiologists, GI doctors, so and so. Yeah.
Excellent. And Muharram, what medical school are you going to?
So doctor, I went to med school in San Pedro, Belize, which is like Caribbean, Central America. So it's called Washington University of Health and Sciences.
Wonderful. Good. Did you graduate?
Like I have a couple more electives to complete.
Oh, wonderful. Okay, sounds good. All right, wonderful. Well, welcome. So
Thank you, doctor.
So I think your observations are pretty much spot on. And so what we did was so this is a tool to talk about this topic. And so we talked about number one, Mohammed, you selected that all these skills were important, right? So the number one was which of the factors, I should say, were important in choosing a consultant. And Mohammed and I were discussing how actually it's all of these factors that are critical. Basically it's not just the skill and reputation, but geographical convenience. I was sharing how personally I think that's an easy one to overlook. because you're thinking like, well, look, if you want to see this, if you need the care, I'm sorry, you have to show up there.
You
Like,
have to
you have to go there. I mean, but that's probably, I think that we don't want to have that expectation of patients necessarily, because geographical convenience can be a major issue, especially if patients don't have transportation, especially if they can't get off for their job, which, you know.
In my pediatric rotation, it was in Chicago at a federally funded clinic, and that's one of the things that the doctor told us was make sure you get a home phone number as well. A lot of these patients don't have cell phones.
Right.
A lot of cancellations because, especially during wintertime in Chicago, because they're all taking the public transportation to arrive there as well.
Yeah. Which community health center in Chicago? I'm curious.
This was it was at St. Anthony's Hospital.
Okay, very good. You know, I did my obstetrics fellowship also at a community health center in Chicago. It was called PCC Community Health Center. It was in Oak Park. It was in Oak Park.
I know Oak Park. Yes.
Yeah. It was West Suburban Medical Center was the hospital. So that's.
West Suburb was where I did the surgery rotation with.
Oh, very good. Yeah, I did my fellowship there. So, yeah, very nice. Yeah, I miss that place. Had I not married my wife, I would still be there. So, all right. So, okay, awesome. So, very good, very good. That's So, geographical convenience. Your experience with the consultant too, because consultants also have an obligation to have some customer service towards the referring physician, actually.
Mm-hmm.
So, and I think we'll talk more about that. So anyway, yeah, all of the above. And then number two, actually, you didn't miss much. We were on this one, and let's see. So we were. Yeah. What do you say? What do you say?
I said, so it would include all of the following, except a directive that catheterization be done as soon as possible.
Exactly. That's exactly right. By the way, just so you know, the longest answer is oftentimes the answer. Just so you guys know. So just keep that in mind. So we were, I think etiquettes. There are certain etiquettes and manners when dealing with specialists. And just briefly, one etiquette is that a few points, not comprehensive, definitely, but a few bullet points regarding the history and the exam and the supporting laboratory imaging and other data. Those are important for a total of maybe 7-8 points, okay, to share with the consultant so that they are thinking, is this worth my time? Because the specialist does not like to have their time wasted. I mean, nobody does. So for them, when they are listening to when they are understanding the referral, they are thinking, okay, is this worth my specialized level of training? As an example, you would never refer a UTI to an ID specialist, right? That would be a joke, okay? So the ID specialist would be like, what is this, Or worse yet, let's say, this is an extreme example, obviously, but let's say you have a 25-year-old female with suprapubic pain and dysuria, and you don't get a UA, and then you refer them to an infectious disease specialist. That would be a joke, okay? So, so they're listening for, is this are you referring for me to do something that only I can do? In this case, we're talking about a cardiac catheterization. That's what the specialist is listening for. So this leads us to the last main thing is D is the type of help you are asking for. For a specialist, what they want to hear is, what is your question? Okay. What is your question? What is the specific thing you want me to address? What a specialist does not want to hear is, here, I have chest pain. Tell me what to do. It's very different, okay? You never want to go to a specialist like, here's the case. What do you want me to do? For the specialist, this can be frustrating. Instead, you want to phrase it as a specific question. you want to share with the specialist, okay, I have this patient with chest pain, or I have this patient with this, this history. I believe that this patient needs a cardiac catheterization. Do you agree? That question is worth their time, okay? Does that make sense?
Yes.
Okay, so this is as opposed to C, where it says a directive. This is kind of the other extreme, a directive that a cardiac catheterization be done. Well, they don't want to hear that either. Because they are thinking, you know, again, they are listening for a specific question. That is what a specialist is looking for. You're not telling them what to do. You may be indirectly sort of saying, hey, I think they need a cardiac catheterization, and you do them. I mean, I'm thinking you should do one. But what you're doing is you're asking the question, and you're saying that I have this patient with the chest pain, a few bullet points on the chest pain, a few bullet points on the exam, a few bullet points on imaging and labs, and then your question, do you think this patient would benefit from a cardiac catheterization? Mm-hmm. That is something the specialist is listening for. It's worth their time. And then they can give you an answer. They may say, you know what? They might be. Send them over. Or they might say, you know what? Based on what you're saying, I don't think so. Here's what you can do instead. Okay? Mm-hmm. Anyway, those are the etiquettes. And it may sound straightforward, but you'd be surprised. Like, so I work with residents, okay? And when working with residents, we always go through this, because sometimes they'll call up the backup specialist and they'll be like, we have this patient, what do we do? And it's like, oh, no, don't do that. Don't do that. The specialist gets very frustrated. Because for the specialist, they're thinking, what do you do? Well, what have you done? I mean, did you even do the basic stuff? And by the way, that's what the specialist is expecting. So as a family physician, you can do a lot, okay? Don't think as a family physician you can't do a lot. You do a lot, actually, especially if the resources are available. So as a family physician, you do a lot before you send them to the specialist. So the specialist is thinking, well, what have you done? Have you done the basic workup? Have you asked the basic questions? So anyway, so etiquette is critical. Mm-hmm. Any questions on that?
All clear.
Okay. All right. So remember the etiquette of talking to a specialist. Okay. Number 3, your communication expectations of the consultant should reasonably include which of the following. So remember, your consultant has obligations towards you. Okay. They need to. So here, you know, especially Muharram, if you're in a community health centers especially focus on closing the loop with referrals. So you send a referral, but then was the loop closed? Was the patient seen by the specialist? And then did you get documentation of that? Then the loop is closed. So a good specialist is aware of that. So they need to communicate with you. So what is the answer here?
All of them?
Okay, good. So all of them, just so you know, all of them is a very reasonable answer for board questions. Have you guys taken your board exams yet?
Taking it shortly,
okay.
By the end of the summer, yeah.
End of the summer, good. Step 1, step 2?
Step 1, yes.
Step 1, okay, good. What about you, Mohammed?
I've done both of them.
Okay, well, then for step 3 then. For step 3, you can, you know. So, okay, so number 3, Muharram, it sounds like you chose A. So Mohammed, what did you pick?
I chose E.
E, well. Yes, I'm sorry, Muharram, you said E as well.
Yeah, he said E too, yeah.
So, okay, so basically, so yeah, that's right, actually. So clear response regarding diagnosis and management plan, that's right. You expect that. Justification for the course of action, absolutely. You know, and it's interesting, when you read the specialist notes, it's almost like a narrative a lot of times, you know, and sometimes they'll send you a letter, not just the note, but they'll send you a letter. Thank you Thank you, Dr. Muharram, for sending us this wonderful patient. The patient presented with this. This is what they presented for physical exam. Really, this is what it seemed like was going on. And after a conversation with the patient, this is what we felt like would be reasonable. The patient is thinking about it. So far, they're in agreement. And it's like a narrative, And so that is in order to include the justification for course of action. And then, yeah, and then it's the actual communication. So they need to get back to you. And so their office will be responsible for sending you back that information. And it's either by telephone or in writing or both, but somehow that communication needs to get looped back. So,
okay.
Okay.
By the way, in Poland, it's a little different. Usually specialists, they write really a summary, a couple words, what they did and what will happen in the future. And the doctors there, they usually make a joke about it, that when a summary of a patient, if it's from a specialist, then it's extremely short because they don't have time usually.
Yeah, it's true. It's true. Yeah. That's right. Yeah, time management is very, very important. That's why when communicating with a specialist, sort of part of that etiquette is respecting their time. I remember when I was a resident, I was my attending told me, we need to refer this patient to GI. So talk to the GI specialist. Oh, it did not go well. Why is that?
Why?
It did not go well because I was not prepared. So this is when I was in training. So I'm talking to the GI specialist. So I'm thinking, okay, they told me to talk to GI. All right, I want to talk to GI. So I talked to GI, but what I failed to understand at the time is that you need to be prepared. You need to make sure that you have all the information in front of you that the GI wants to know. So the GI does not care if they had the GI doesn't care about what their chest x-ray showed. Usually, but I was ready with their chest x-ray, but the GI wanted to know, did they have imaging of their gallbladder before? And I didn't know. The GI wanted to know, have they seen a GI before? I didn't know. Okay. Stuff like that. The GI wanted to know what their lipase level was. I didn't know. Yeah. So that was very bad, very, very bad. So I remember that. So okay, fine. I didn't know. Okay, that's okay. So what I needed to do was to say, Dr. So-and-so, you're right. I apologize. Let me come back to you when I have that information. I do apologize. Instead of what I was trying to do was to say, oh, let me see. Let me look it up and see. That's not going to work. The GI specialist has places to be. They're in the hospital rounding. They're not going to sit there on the phone waiting for me to look stuff up. So that was, I'm glad that was a long time ago. That was very scary. So that's not acceptable. And so that's why you need to be prepared, have those bullet points ready, have the specific question, so that, because what you're doing is you are respecting their time, okay? Because that's the, and you're busy, you're busy, they're busy, they may be even more busy. So, okay, that's enough about that. Let's go to number 4. Your patient sees the consultant and returns to see you 3 weeks later, confused by what was told to him by the consultant. You call the consultant, but are told by the receptionist that she is too busy right now to come to the phone. Okay, that happens. They may not be available at the moment. Options at this time include all of the following except. Okay, so let's say you send a patient to the specialist. The patient goes to the specialist, and then let's say the patient comes back to you, right? But the patient comes back and you didn't get the documentation yet from the specialist, right? And this is very common. This is common, actually. You may not have it right away. And the patients oftentimes can be very confused by what's going on. So your job as a family physician and as a primary care physician is to say, okay, let me help explain this for you. So I remember I had one patient who went to the cardiologist. And actually, it was kind of like this, actually. Went to the cardiologist, and she said, you know, the cardiologist said I need to be on a blood thinner, and I don't think I need to be on that. So this patient had AFib or A-flutter. And it was like, and so as she's explaining this to me, I'm like, I don't know. It sounds like you need to be on a blood thinner.
Yes.
So then it's like, okay, well, look, here's what we're going to do. Let's get the records. So we got the records. And when we got the records, we said, okay, ma'am, okay, I see the records. It is because I don't know. Maybe, you know, you don't know what's going on. I mean, it sounds like AFib, A-flutter. You need to be on a blood thinner, but I don't know because I don't know what the cardiologist actually said. You know, and you want to be very careful about what the patient says, the specialist says, if that makes sense. A patient will say, the specialist said this. You don't want to just believe it without verifying it. That's not appropriate. I mean, they could be right, okay, but you really don't know what the specialist said, okay? Even if the patient says what the specialist said, you need those records. So then for this patient, we got records and we looked at it, it says, and it was like, yep, you have AFib. You need to be on a blood thinner, no doubt about it. And then she says, doctor, do you really think I should be on that? Yes, definitely.
Now you know for sure.
Yeah, I know for sure. And now I'm in and the thing is, a lot of times patients, they trust you more. Because not always, but many times they do. They trust you more. So they may end up listening to you instead of the specialist for whatever reason. Some patients are the opposite. It's normal. So then this patient, she started on her thing. But then I was reading in the notes and the specialist said something else, right? That the patient never mentioned. The specialist said, you also need a cardiac catheterization. And then it was like, ma'am, you need a cardiac catheterization as well. She said, oh yeah, they mentioned that. Yeah, I'm not doing that. I'm like, well, okay, well, you can choose not to do that. But here are the risks, here are the benefits. Well, do you really think I should do it? And then you look at the specialist notes. Yep, I do. I agree. I don't have any reason to disagree with what the cardiologist is saying. She says, okay, fine. So you see how...
So she changed her mind just because
Definitely.
of the relation you have with her. Yeah.
Definitely. And these things can make a big difference in the outcomes of a patient, okay?
Yes.
Okay, so what are the options here? What did you guys say?
I chose B, maybe to send her again to the consultant.
Okay. So very interesting. So the answer here is
it C?
Thank you, Muharram. Thank you for chiming in. So excellent. So Muharram felt that the answer is C. Okay, well, let's look at them. So A, speak to the physician later that day when she is available. Okay.
Can be.
B, ask the patient, and Muhammad is using the thing about it's the longest answer, so it must be right. Ask the patient to return to the consultant for another visit to get a clear understanding of the recommendations and plan. C, not using this consultant again. D, seeking the opinion of another consultant if communication does not improve. So you see what they're saying here. What they're saying is that the specialist is not communicating optimally. Oh, let's see. Let me hold on one second. I have my Zoom only gives us 40 minutes. And this is new to me. I didn't know Zoom gave you a 40-minute time limit, but I think they're giving us more time now. So I guess we can go with it. You know what I'm thinking, guys, though? Because of this time limit, I made 2 meetings, actually. So maybe what we can do is, I'm thinking, do you guys have the link for the second meeting?
Yes.
Yeah, on the email.
Yeah, okay. Why don't we, I'm not sure. Should we keep going or should we, Or
It's
just
still
log in?
working, so maybe
It's
we
still
can.
working. Yeah, we
Yeah.
should probably just keep going. Let's just see what happens. So if we break up, if for some reason they cancel it, we have that
Rejoin
second
with
link,
the
okay?
other.
Second link.
Okay.
Okay, yeah. I wonder, do you guys know if you have to pay for this upgrade for Zoom or?
I think there is a version of Zoom that you pay something for as well.
Maybe
Yeah.
maybe that's what it's going to be doing. I don't know. Okay. Okay, well, let's keep going and let's just see what happens. If we get disconnected, we have that other link. Okay. Okay, D. Well, anyway, D was sort of hinting that the communication with the specialist is not optimal, right? You didn't get documentation, you're calling, you're like, okay, I don't have anything here. So E is asking the receptionist to fax the consultant's letter of consultation if there is one. So basically, very interesting. So it looks like the actual answer here is B, apparently. Very interesting. Let's go through the rationale. So it says this is basically this scenario is what to do if the consultant has not fulfilled the expectation for communication. So it looks like here, 3 weeks ago, the patient was seen 3 weeks ago. So the ideal thing is that the specialist probably should have had something to you by then. Okay,
Yeah.
3 weeks probably is too long not to have documentation. So this is the main reason why, like if this was 2 days after the patient was seen by the specialist, well, 2 days is not a lot of time. You may not have gotten the notes from them, but 3 weeks probably you should have. Okay, now let's see what the rationale is here. Because to be honest, I was tempted towards E, to be honest with you. Okay, so now direct communication is imperative, and the staff member actually should have been more helpful. Actually, so the receptionist, she should have helped you out instead of saying, "I'm sorry, the specialist is not available right now." The receptionist should have said, "Oh, absolutely. Let's."
Oh, but it's accept, so maybe E is an option.
Okay, very good. So you're right, Mohammed. Thanks for pointing that out. Yeah, because I was thinking E is kind of reasonable.
Makes sense, yeah, to do,
So B, again, it's the longest one. So that's good. I feel better now.
Yeah.
I feel better because I was like, dude, I don't know if I would do that. But anyway.
Yeah, because I saw it said accept, then I was like, well, maybe it's still too early to not use this same consultant again, and maybe we should,
Yeah. No, excellent point, Mokharam. And that can vary based on the part of the country that you're in. Maybe New Jersey, it's super busy. Maybe the Midwest is different. Maybe the Midwest is like, dude, I need a note by like today. So it's a little bit different. But this is accept. Yeah, always be careful with that one. So anyway, so that makes sense. Yeah. So yeah, generally, again, you want to, to me, that makes sense. I mean, I would not say, okay, just schedule another appointment with them,
Okay.
Yeah. So good. So let's go through the rationale just a little bit more here. So direct communication is imperative, and this staff member should have been more helpful. She knows that the patient was sent over, so she should say, "Oh, you don't have the note? Oh, let me make sure I get you the note." Or she, instead of saying that, "Oh, the specialist is too busy," she could have said, "The specialist will absolutely talk to you. Could they call you later that day?" I mean, lots of options that the receptionist could have done, but she did not do that. Requesting the consultation notes is perfectly reasonable. Good, I feel better about that. But in this case, it does not substitute for a formal written communication. So that's actually very interesting because it makes the distinction between the note and a letter. usually when specialists send stuff back to you, it's both. Remember that narrative? Oh, thank you so much. I enjoyed meeting them, stuff like that. There's the letter, and then there's the actual note itself. To be honest, usually nowadays, I just get the note. A lot of times I don't get the letter, to be honest. But to request the note usually it's good enough, actually. You look at the note and you see what's going on. And now, the reason why B is inappropriate is because this is inconvenient for the patient as well.
Yeah, it's not their job.
Yeah, it's not the patient's problem. It's not the patient's problem that the specialist didn't send over the documentation. So for the patient, they'll be like, let me get this straight. You're asking me because you guys did not do your job. You're asking me to, again, take time off from work and lose pay, again, find transportation. And by the way, there's no guarantee that you'll get the note this time either. So, so that's why. And then, of course, Muharram, you are correct. You are correct in the sense that, you wouldn't use this consultant again necessarily because you're like, this communication was not optimal. So you are well within, you're well within that reasoning. So, okay. All right. Any questions on this one?
That would be it.
Yeah, okay. Of course, calling later that day is perfectly reasonable. You're like, I'm sorry, I need to get a hold of them. Not using them again. Now, this is very interesting. Seeking the opinion of another consultant if communication does not improve. Absolutely. You may need to refer somebody else. Actually, I did this with my patient, by the way, actually. So before this cardiologist, she was seen by another cardiologist. And she was like, it wasn't that communication wasn't good, but the patient just hated that cardiologist. She said, I am not going back there. So then it's like, okay, let's send you to somebody else. Okay. All right. Okay. Number 5.
Dr. Murad, do you ever disagree with a specialist action plan, care plan for the patient, or had certain disagreements with, or?
Well, before going into that, Muharram, what have you seen? What have you seen happen with that situation?
So like what I've seen is like I would say like overall, the family doctor I used to work with in Chicago, with that I did my core rotation with, she would generally agree, but there were certain times in which she was like, no, I don't think you need this surgery. Your spinal stenosis is not that bad yet. Or I think we should try physical therapy first, or more conservative methods first, because it's my job as a family doctor to make sure you have less surgeries as possible, less hospital stay. And if I could take care of something outpatient, I'd rather do that. Stuff like that. But not too much, but maybe just once or twice.
Mm-hmm. Yeah, I think that when that happens, it's good for it to be based on clear evidence and clear guidelines. Yep. That's so. So when a family physician does that, that is important because, family physicians are known to provide the most, I need to be careful because there needs to be evidence for this too. But in general, family physicians provide some of the most cost-effective care. And the reason why is, a way to do that is to base management decisions on evidence and best practices, consensus guidelines and so forth. So, or established clinical guidelines. So when you do that, it is usually based on that. It's usually, and that will, and clinical guidelines will oftentimes, because, they need to be evidence-based as much as possible, they will oftentimes include recommendations for conservative care in appropriate situations. So if you see a situation where, based on evidence, based on clinical guidelines, conservative care is appropriate here, that is where you have justification to recommend that. So for example, if somebody has if somebody has a 12-centimeter uterine fibroid, okay, a
It
12
needs to come
centimeter,
out.
it's like, yeah, I'm sorry, hormones is not going to help with that. There are no clinical guidelines anywhere that says conservative care helps with that. So in that case, it would be inappropriate for me to recommend conservative care. But in other situations where you have chronic back pain and physical therapy was never done, conservative care was never done, there's no emergency, there are no red flag symptoms, and you see that there's a gap in the care where, I'm sorry, based on the clinical guidelines I go by, there's a role here for conservative care, and there's a gap here, it wasn't done, then that's where you're justified in doing that. And then you say, the other sort of part of it is you make it more patient-centered. So maybe the specialist may not be wrong, but maybe that patient doesn't have insurance, and maybe there's an opportunity to do more, there's an opportunity to do more conservative care, and it's reasonable, it's an option.
Yes.
And maybe the patient is scared of surgery, maybe they had a bad experience, so then there's it can be more patient-centered where you say, okay, look, I think for some patients, yeah, sure, surgery would be the best option. But for you, it's reasonable to do this. So it should be based on clinical guidelines, and usually it's a patient-centered kind of shared decision-making as well.
Shared decision.
Yeah, so those are the times, that's sort of the situation where it can be reasonable to deviate from what the specialist recommended. And it's not like you're saying the specialist is wrong. You can say, well, let's do this for right now, and
then
if, yes,
if needed. But dealing with insurance companies has been like, I hated it so much, just being on the phone for hours, and
it's awful. It's interesting. It's interesting you mentioned that, actually, because so I also see a lot of uninsured patients, and we encounter challenges of the patient not getting into the specialist at all. So then I'm like, wow.
You are their specialist then?
Was that?
Do you end up becoming their specialist to a certain degree?
Actually,
as well?
Yeah. And that's why in family medicine, it's important to be broad. It's important to be able to take care of patients as much as, and I can assure you, I do a lot, in the sense that, like, a patient may have rheumatoid arthritis, okay? So what I was actually explaining to Mohammed earlier, back in number one, in this case, not number one, in this case, it talks about joining a practice with a nurse practitioner and physician assistant. So Mohammed and I, because Mohammed is in Lebanon, by the way, you guys need to introduce each other. But we were talking about the mid-level providers.
Yes.
So, and then you supervise them. So, a lot of times what we'll see with mid-level providers, like, oh, you might have rheumatoid arthritis, we're referring you out. And it's like, oh, no. This patient has no insurance. They're never going to see a rheumatologist. Never. They will never see a rheumatologist, okay? So actually I said, well, as a family physician, let me see the patient. And, for me, if I have the right guidelines and the right resources, maybe I haven't done a lot of rheumatoid arthritis lately, but I received training in it. And I can, if I have the updated guidelines and recommendations, I can do it. So I do that. So, I say, okay, let me brush up on this. Then you practice and you prepare for the appointments, and and you're able to do it. And so now, I've diagnosed lupus, I've diagnosed rheumatoid arthritis, and I manage them because you can. And then at some point, if it becomes too complex, then it's like, okay, now they need to go to a rheumatologist. But I haven't encountered that yet, to be honest.
Okay. So like maybe when they're in like a rheumatoid crisis, or like they're having a crisis attack, that's when it gets a little bit too much.
Yeah, or if it's refractory to care. So if you're prescribing, and there's a lot you can do before you get to that point. And every patient I've had has not needed to go to a rheumatologist thus far. You know, so that's an example on how, as a family physician, you can do a lot, and you need to, that's why it's important to keep your medical knowledge as good as possible, to always continue to learn, and use practice as an opportunity to learn as well. And I'll mention, just so you guys know, I'll mention that when it comes to patient care, let me stop share for a sec, actually. I want to share with you an excellent resource that I use. It's right here. It's my email. But let me actually do this. I go to the AAFP.
Mm-hmm.
Okay, that's the American Academy of Family Physicians.
Mm-hmm.
Let's just do rheumatoid arthritis. Okay, as you can see, I visited it before. Diagnosis and management of rheumatoid arthritis. It is beautiful. It is beautiful. So when it comes to actually, like, let's say I'm preparing to see a patient, and it's like, okay, they have rheumatoid arthritis. What do I want to do? I don't prepare like 2 minutes before the appointment. I may know what my schedule is, and the day before, I may decide, okay, what do I want to do? This, like, even this synopsis, this abstract is beautiful. It tells you almost everything you need to know. And then the articles by the American Academy of Family Physicians are phenomenal. They are phenomenal. So as a family physician, I have the resources to take care of patients as much as possible before referring them to the specialist. And that's the thing, like the mid-level providers, they say, oh, they have a positive anti-nuclear antibody, I'm referring to a specialist. For the rheumatologist, they're like, okay, did you get a rheumatoid factor? Do they meet, what's their physical exam like? Is it pretty obvious they have rheumatoid arthritis on physical exam? Did you try anything? You know? I mean, so for the rheumatoid arthritis, they hate that. They hate that. But if I send them a patient and say, I have this patient with rheumatoid arthritis, here is their lab work, here is their clinical exam, they meet criteria. Therefore, here is the treatment that we started, and here is how the treatment was escalated. Here's their clinical course after their treatment was started and escalated, and they are refractory to care. Now the rheumatologist is interested, okay?
Mm-hmm.
Okay, let's go back to our thing here. Okay, what question are we on?
Number 5.
Okay, you later learn from the patient that the consultant has, oh, this is good, that the specialist has referred the patient to another specialist without your knowledge. Circumstances and reasons why this is a problem for both of you and the patients include which of the following? Why is this a bad thing? What would you guys say?
All of the above.
Yeah. All of the above. Yeah. Sometimes, like, for example, let's say you referred the patient to the cardiologist, right? And then here's what patients do, regardless of what they're seen for. Okay, regardless of what they're seen for, the patients will say, like, they go to the cardiologist and they say, well, I'm here in front of a doctor, let me bring something else up. So they'll tell the cardiologist, oh, hey, I have this rash. Okay. So this is the reality of what happens. So the cardiologist says, rash. Okay. Let's see. Rash is skin. Skin is dermatology. I'm going to refer you to a dermatologist. Okay. So then the cardiologist will do that. Or the patient may say, I'm having trouble urinating, doctor. And the cardiologist will say, urine. Urine? That sounds like kidney? Bladder? That sounds like urology to me. I'm going to refer you to urology. Okay, so this is what happens. So, Mohammed, you agree that all of these are okay? Such behavior disrupts the continuity of care. Yeah, because what should the specialist say? What should the cardiologist say in that situation?
See your if it's something he can't do, please speak to your primary care physician.
Yeah. That's exactly right. So that the family physician can do as much as he or she can. And then if the family physician, in the 1% of cases that they need to see a urologist or whatever, can do that. And yeah, so it's a very disruptive to the continuity of care. Continuity is defined as the same provider seeing the patient. That's like the definition of it. If you have the more providers you have seeing the patients, the less the continuity. Now, of course, sometimes that's necessary. The patient's condition may warrant multiple people, multiple specialists involved, but you don't want it more than necessary because that impedes continuity. So that's sort of the technical definition is, for the visits seen, how many of those visits were seen by the primary care provider? Okay.
I would add something quickly.
Yes.
Commenting on what Quran said, how a family physician can deviate from the recommendation of the specialist is usually polypharmacy when a patient, especially elderly, when they are seeing a lot of specialists,
Right.
each one is giving them a different medication. So a family physician's job is to see all this list and see what can have like cross reaction, for example, or something more than necessary for this patient.
Right. Exactly. That's exactly right. So Mohammed brings up a very interesting correlation between lack of continuity and polypharmacy. Absolutely.
Absolutely. And I've seen like where the family med doc would be like, okay, you don't need to be on 3 different blood thinners. Like you can, like we can, stuff like that. Yeah.
Right. Exactly. Excellent point. Yeah. You see?
Yeah.
You see? Exactly. Okay.
I think they call it a med wash. No? Or maybe in psych they do at least.
Maybe. Yeah.
I've seen with psychiatrists, like if they already be on a whole bunch of like psych medications, and then the psychiatrist would be like, well, I don't know what's working. I don't know what's not working. Stop everything and slowly continue, restart the whole process all over again.
Right. Absolutely. So excellent points.
Yeah.
And it may result in unnecessary use of additional resources. Oh yeah. So, so specialists, their care is more expensive. Okay.
Yeah.
They will more likely use more expensive technology, more procedures involved. Okay. So, and it may not, if the family physician saw them, the patient may be adequately treated without that. So what happens is family physicians function certain, when you look at the spectrum of care that a patient receives for a certain diagnosis, okay, 90% of that spectrum, the family physician can do. 10% of that spectrum, the specialist does. But that 10% that the specialist does is way more expensive than the 90% that the family physician does, okay? So if you're going to the specialist, automatically that care is way more expensive when that care could have been in the 90% that the family physician did, okay? Not the least of which, by the way, you just go to a specialist appointment, just the visit is more expensive, so. The problem may have been handled by you. I think we talked about that. And it may add unnecessary inconvenience and expense for the patient. I think we talked about that.
Yeah.
Inconvenience too, by the way, when you have to get set up with a whole new doctor's office, oh my God, you have to figure out how to get scheduled there, where are they located? Maybe that's geographically inconvenient.
If you need prior authorization.
Exactly.
Yeah.
Who's going to do the prior authorization? Exactly. Excellent. Good. So we can see why for the specialist in the moment, sure, let me just send you to dermatology, but we can see what's the better route. Okay.
Sorry, what is this prior authorization that is needed?
Muharram, please introduce Muhammad to American medicine and share with them what prior authorization is.
Okay, so prior authorization is that before the insurance company is willing to pay for a doctor's visits, any procedure, imaging. So someone like Dr. Murad would have to send a letter to the insurance company justifying why the patient needs so-and-so medicine, so-and-so procedure, or so-and-so imaging study. And then the insurance company will be like, okay, I think you're right, we will pay for it. Or they'll be like, nah, we don't want to pay for it.
You should give them a good reason why you really need this referral,
Yes.
for example, and then they can cover
Yes.
it or not.
I mean, one of the things I had was a patient, a family medicine doctor was seeing this patient that had a sprained ankle, and it was still hurting a lot. There was still some like, you know, you could see some diffusion, inflammation going on there. Um, so we were like, okay, maybe we need some more advanced imaging because it's been like 6 months already. So the doctor was like, I think an MRI or something like that. Maybe something was damaged. The insurance company was like, no, we need proof that you did x-rays, physical therapy, and you know, conservative management first. So I had to type up a whole letter stating they took this medicine, they did the whole rice therapy thing, they did at least 3 months of physical therapy for them to even consider paying for a procedure.
Okay, understand. Okay,
Yeah.
Thank you.
Yeah.
All right. Well, looks like we have about a half hour left together. So I think, Mohammed, if we don't get to that presentation, that's fine. That's fine. I think that's just extra.
I can send it to you if you want, or
Yeah, send it to us. Yeah, that sounds fine.
Yep.
That sounds fine.
sure.
Okay, guys, let's get through clinical case problem 2. You attend your first meeting of the practice clinicians, which again includes those mid-level providers, and staff like the secretary, administrative assistant, the office manager. The practice leader says she wants to improve teamwork in the office. She defines teamwork as people working together cooperatively and effectively. Knowing that you have just graduated from a residency program known for its team-based care, she asks for your advice. Okay. Now, I will say that teamwork, it is such an important topic. I feel like almost it's a topic by itself. But team-based care is very critical. Medicine is a team sport. Okay, it is a team. So you know how you have a soccer team? You have a soccer team that works together to score a goal? It's the same thing. It's the same thing in medicine. People work together to accomplish certain goals, okay? And it's very important that people work well together. I can tell you that sometimes people do not work well together. Maybe the mid-level provider does not interact well with the collaborating physician, for example, or maybe the office manager does not interact well with the clinicians, or maybe the administrative assistant does not, or the receptionist out front does not interact well with the nurses and the clinicians in the back. Many different interactions, okay? And
I've seen this a lot in person, Dr. Murad. When I was at Atlanta, I did some ENT fellowship elective in Atlanta Medical Center, and it's just the anesthesiologist and either the GI doctors or any of the surgeons are always just going at it back and forth. And I was like, oh, like they're both adults here, and they're just really just going at it back and forth.
Yeah, you'd be surprised. It's a lot of drama.
Or where like a anesthesiologist is like to a mid-level anesthesia provider, because CRNA is like, where did you go to school? What are they teaching you nowadays? And I'm like, we're in the OR though.
Oh wow. Yeah. That, professionalism is so important. Professionalism, etiquette,
Absolutely.
manners, courtesy, respect. These things are critical. At a minimum, you have to have this. And teamwork, what happens is that if teamwork is not good, then the actual clinical outcomes suffer and the quality suffers. There's a chapter, I guess we'll be doing quality improvement later, but quality improvement does not happen without good teamwork. So, my full-time job nowadays is administration. So I practice, but I don't actually. I feel like it's 2 full-time jobs, to be honest. But the when you practice, but in administration, you see this very clearly. So the office manager here, you see that the practice leader sees that, okay, we need to improve teamwork for the sake of good outcomes for the office. So number 6. So yeah, Muharram, good,
Yeah.
good stories to share for sure.
Yeah.
So number 6, factors that improve practice functioning and teamwork include all of the following, except, what would you guys say?
Using mostly written communication.
Let's see. Using mostly written communication. Okay. So all of the following except C. Okay, Mohammed, what do you say? Mohammed, I think
Fairuz.
Mohammed froze. Yeah, Mohammed, are you there? What would you say?
I'm here.
Okay.
Yeah, yeah. I was thinking either B or C.
Let's see. B or C? Okay, pick one.
Oh,
Gotta take step 3. Gotta.
no, I didn't take step 3, but soon, I hope.
Oh, no, I'm saying you have to take step 3. You still have to
Yeah,
take step
yeah.
3. So yeah, we need to practice these test taking.
Yeah. I'll just go with D. Let's see if he chose C then.
One of us will be right.
Okay.
Yeah,
Maybe.
should.
So 6, the answer is C. Using mostly written communication. Now remember, this is all of the following except, right?
Except.
Actually, it's a very interesting thing. Well, let's kind of go through it. So building trusting relationships. Well, that
Sure.
kind of
Yeah.
makes sense, right?
The whole point. Yeah.
Yeah. Now, trusting relationships, you know what that means in practice, I think is that you trust the other person to you're not afraid of being harmed by the other person. Okay? That's kind of what trusting relationship means. Like sometimes you will encounter people in the medical profession that are not that unfortunately for whatever reason they may not be as professional as you would like, and they actually do things that are like that it breaks down trust. They're not supportive. Okay, they may not support you, they may not support other people, and I'm sure you guys have many stories about that. But you encounter people, they clearly don't support you or they don't support other people. You don't trust them, okay? You don't trust them. That is not good. That is not good, okay? It needs to be a trusting relationship where you believe that you will support each other in the process of taking care of a patient, okay? So when things get really bad and you just don't trust other people at all, patient care suffers in the end. Okay. So anyway, that trust is important. Having a diversity of perspectives. So very interesting, Mohammed. You know, the diversity of perspectives is very key actually to a good team. The reason is because no one person sees everything, okay? I'll give you an example. Like yesterday in clinic, I felt that we had to do what? I felt like we had to do a procedure at the same time as the office visit because I felt like she needed it, okay? So I was like, okay, you know what? I think that we need to do this procedure. So I told my medical assistant, I'm like, okay, we need to do this procedure. So then another member of the team came and said, Dr. Murad, I don't think we can do this procedure for this reason and that reason and that reason. And I said, oh, you're right. We can't. You're right. So you see, so I'm the physician, right? Which in that team was the highest level of training, right? Also, I'm an administrator too, which means that potentially you have the authority to do, if you wanted to do this procedure, you could do this procedure. You have the authority to do that, okay? But I did not see everything. And the medical assistant came and said, oh, Dr. Murad, I don't think that you could do this procedure today because of this, this, and this. Okay, so you see the diversity of perspectives. She sees things I don't see all the time, okay? And not only that, but going back to I trust her. I trust her. I know that she is supportive of me and she is supportive of the patient's care that we're doing. So I trust her and she has this perspective that I don't have. And because of that, the patient's benefited because of that.
Okay.
And this, this happens a million times a day, okay? If I did not trust her, maybe I would have said, I don't trust you, I'm doing it anyway. or if it was not a trusting relationship, maybe she would have said, well, I don't care, he can just do whatever he wants. And then the patient would have suffered.
Oh, yeah.
Or if there was not a diversity of perspectives, we would have never known that we should not do a procedure that day. Okay? But we had a trusting relationship, we had diversity of perspectives, which means the more diversity you have, the more things you're able to see and know. So diversity is very key. By the way, this is very important for patient safety too. So for patient safety, one of the hallmarks of patient safety is that anybody, if they see an unsafe situation, anybody can say something, even if it's a medical student or the, not even a nurse, but a medical assistant or something like that. Anybody can say something if they see something unsafe. That is a hallmark of patient safety. So regardless of whatever it is, they can say something, and that reflects, that acknowledges the diversity of perspectives. Somebody may see something that the nurse or doctor may not see. So that diversity is very important. So, okay. And so you can see why it's critical for team care and for patients. Using mostly written communication. Well, I would agree with you guys that this probably is not a hallmark of team care, because written communication, while it's very important, there's a lot of verbal communication as well. And by the way, communication is not just verbal, but it can be in person and nonverbal. So if I'm communicating with someone, but I'm screaming, well, this is not good, okay? That's not going to, that will make people fearful and not trusting, okay? So that's why it's important to not scream and yell, okay? And I'll be honest, I'm guilty. Now, don't get me wrong, I don't like scream like a maniac, but you know, sometimes you're in situations that are frustrating and you're agitated as you're communicating. So that sometimes, while it can be understandable from time to time, you really want to keep that to a minimum. You know, when you communicate, you want to be professional, you want to be calm, you don't want to be agitated. And, you know, you see specialists and doctors sometimes being agitated and, you know, and okay, but for us, okay, we want to minimize that, really keep it to a minimum. We want to be calm, we want to be respectful, professional, all that stuff, okay? So, so I'm guilty not of like screaming like a maniac, but I think sometimes maybe being agitated. So that's something personally I think I need to look at. But so the communication is nonverbal and verbal. In fact, D says encouraged varied interactions. You need to encounter. And by the way, as physicians, we are notorious for not being good with email. Okay. So for me, I struggle with that because I feel like when you're doing patient care and administrative stuff, it's just really hard. So for me, I'm like, okay, look, I'm going to Panera first thing in the morning and I'm getting my email done at Panera. You don't have Panera in Lebanon, Mohammed, I don't think. Oh, okay.
No.
Coffee
It's a
shop.
cafe? Oh, okay.
Yeah. Muharram, where are you from originally?
I was born in Pakistan, but I've been in the U.S. since I was like 2 years old.
Okay, Muharram, we're very similar. I was born in Egypt, and I've been in the U.S. since also like infant.
Yeah.
So,
and up until last year, I was actually in Brooklyn, New York, and we just moved to Jersey like a year ago.
Wonderful.
Yeah.
I would love to go to New Jersey. I hear there are a lot of Egyptians in New Jersey. So.
There's a lot of Egyptians here. It's called Patterson, New Jersey. It's all Arabs. All Arabs.
Yeah. That's right. Okay.
I do love Egyptian kunefa.
Kunefa.
You should try the Lebanese one, by the way.
Actually,
I tried the Egyptian and the Palestinian one.
Palestinian, same as Lebanese, by the way.
Oh,
yeah. So
okay, it's pretty good. Yeah.
Very good. Absolutely. Actually, I was talking with Mohammed about, in Egypt, they're very famous for their acting.
Yeah.
And to be honest,
Best in
honestly,
Arab world.
what's that?
They are known to be the best in the Arab world. The
Oh,
Egyptian acting is the best for sure.
oh yeah, yeah. No, but I was telling Mohammed, actually, I think that the best material for acting is from a long time ago, to be honest. Like, I think, like I was sharing with Mohammed, there's some soap operas that were from the 90s. And I grew up I was a child of the 90s, to be honest. And I never saw this stuff growing up. But now with YouTube and all,
Oh yeah.
YouTube and Hulu and on all this stuff, oh my God, like I am totally watching all these soap operas. And
Awesome.
oh man, they are amazing. Like, I think the acting in Egypt, I think it's better than here, to be honest.
Oh wow. It might
Oh,
be.
yeah.
It very well might be. Yeah.
Oh my God. But I think the writing
The writing is really good.
oh, it's so good. And even like the black and white movies from
Yes.
a long time
Classic.
ago, classic
Yes.
stuff. Oh my God. There was actually this one thing. I don't know if you guys saw on Netflix. There was this Egyptian, like I don't know, Mohammed, did you catch this? There was this thing on Netflix. It was an Egyptian like miniseries. It was called Paranormal. Did you hear about it?
I saw it, but I never
Unfortunately,
got to watch it. I mean, I saw it
Yeah.
on Netflix, though. Yeah.
Muharram, I am
Yeah.
not a fan. I think, oh, no. Oh, Muharram, oh, please. The writing was, oh, let me tell you something. Okay, we don't have time. Muharram, the writing, it had great special effects, okay? Like the special effects and the screen.
That's what movie is nowadays, or like shows.
Yeah.
Special effects, but like
Yeah.
no acting or storyline.
Oh my God. Oh my God. It was so awful. It was the writing was so, it was literally a mix. It was a mix. It was called Paranormal, right? And so it sort of started off like Paranormal, like the actual Paranormal here in the US. But it was literally they mixed Paranormal, Jurassic Park, and Indiana Jones. It was literally a mix of all that stuff. It made no sense, okay? It made no sense. It was awful. I'm like, you know what? The heck with this. I am watching an Egyptian Tamsaleya. That's where it was. Anyways, yeah. I'm sorry, guys. Went off on a tangent. I apologize.
It's okay.
Okay. So varied, and so I'm not quite sure how we got there, but yes, varied interactions, how it's nonverbal communication plus the verbal communication, very important actually. In addition,
do you text doctors a lot too, or specialists that you're close with?
Okay, so here's the thing. Yes, I do. And you know what's interesting, Muharram? A lot of students I've had in the past are now specialists. So
Okay.
it's a personal network. So indeed, you're correct. You will use your personal network in addition to formal communication routes. So and that's okay, actually. And as a family physician, I benefit from that because I have students that are now specialists that I will talk to them actually, and so I can learn. Okay, in this for this condition, what is the latest best practice for this condition now? Because I may not know, So. Okay, so yeah, texting, email, verbal, nonverbal, all of that, and then communication in the EMR. Communication.
Yeah.
Oh, by the way, yeah. And so this is another thing for professionalism as a family physician, is that your EMR inbox, that's like your work, okay? That's the work that you have to do. That is very important to get through in a timely fashion, because nowadays, you guys, you're not just communicating with the specialist. You know who else you're communicating with through the EMR?
With the patient as well?
The patients.
Yeah.
Yeah, definitely.
Oh yeah, the patients can log into the portal to view stuff or
That's exactly right. That is exactly right. So now, and it's interesting, this chapter that we're sharing was maybe a few years ago. The patient portal at my organization, most of the messages I get are from patients. Yeah, and it's beneficial. It does help. And when I send patients messages, it's through the portal, but also at the same time, it's by what? It's by text message too.
because it probably converts it or
Yeah.
yeah.
And not only that, Muharram, it's by portal. The same message goes by portal, it goes by text message, and then it goes as an automated phone call.
Oh wow. Okay.
The same message, yeah. So
Nice.
you see, I am communicating with the patients as well, in addition to all the members of the team. And when I and so you can see how communication is so key. So when it comes to your electronic health record inbox, you need to be on top of that, basically.
Mhm.
Okay.
Speaking of like EMRs and stuff, like doctor, are your notes like very detailed, like, or is that something to just torture medical students to do?
Oh yeah. You know, do it
Because I
as,
know when I go to my primary care doctor, like
yeah.
his notes are like some random words and like, you know, nothing like, but like for us, it's like each symptom has to have its own line with 3 positives and 3 negatives. And okay, and then the second system has to be its own and this and that. And I'm like, am I going to be doing this and seeing patients in the future at the same time?
Yes, you will. Yes, you will. Now, here's what I suggest. Actually, number 8 talks about
Yes.
the EMR. Well, indirectly, but yes, you will. Okay, and what you are obligated to do is to get acquainted with the EMR and what you will do for clinic. Okay, so here's what I do for clinic is I look in my EMR, use the EMR to your advantage. So my suggestion is are some EMRs lousy? Yes, but
Yes.
but my personal recommendation, try not to get too caught up in that,
Okay.
because try to do this. Look at your EMR, okay? Try and get familiar with the features of the EMR.
The different templates and everything.
Different templates and things like that, yeah. Think about how you want to prepare for clinic, okay? So here's what I do, which is not what everybody does, but here's what I do. I look in my EMR and I see what, you need to get familiar. How do I order things? How do I make referrals? How do I do templates? How do I get my note done? Get familiar with these things, okay? Because you have no option. You have to get familiar with it. And then what I do is I look in the EMR and I become familiar with how to do these things. Then what I do is I think, okay, your EMR is a tool for you. So for me, I think I make myself, when I prep for clinic the next day, I make a list of all the things I need to get done for that visit, okay? Nowadays, I just don't show up to clinic. I just don't show up and be like, all right, what we got going on today? Yeah, what's going on, I don't do that anymore. Why? Because as a family physician, I see patients that have many problems, many issues. And sometimes I need, and because it's a very broad number of things, it's not something, for me, I benefit when I prep for it ahead of time. So in an hour and a half, the night before, it's like my homework. I look and see, okay, I look at the EMR. I'm like, okay, what is the patient coming in for? What labs did the patient have done? What did they, what have they had? Like, what's going on with this patient? I don't know, like, what were the past visits like? I look at the outside records, okay? And so I use the EMR as a tool to help me prepare. So then when I see the patient, I try not to do too much thinking at the time of the appointment. What I do is I make myself a checklist. And I make myself a checklist of, okay, when I see the patient, I need to do this, 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 and this, okay? This is what I need to do in the EMR when I see the patient. So I make myself that list so that when I see the patient, I go through my list, and that list may be 5, 6, 7, 10 things, maybe more, depending on what's going on. And if I get all that stuff done on my checklist, I am done. And my note is done too, okay? So I try not to get too caught up in, the EMRs, that they have these features that I don't like, but try to, as you get familiar with the EMR, use it to help prepare for clinic and make yourself a checklist so that when you're in clinic, you just hit up your checklist. You're like, boom, 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 I'm done. I'm going to move on to the next patient. The other thing is that when you prepare for clinic the next day, actually you're in the EMR. Most of the time, your EMR, you have access from home. Usually. Yes. use that to your advantage. So then what happens is I'm looking at my EMR. I mentioned I like to go to a coffee shop, right? That's being Egyptian, by the way. Just want you to know. So I wish I could just do everything at a coffee shop. But so Mohammed, just so you know, Mohammed, there's a company, there's a restaurant called Panera.
Mm-hmm.
Dude, they need to open up. They need to open up locations in Egypt. That's all I have to say. Although in Egypt, they don't have free refills in Egypt, I noticed. So anyway,
yeah, I don't think so.
Yeah. So anyway, so you could be at Panera preparing the next day or whatever.
Mm-hmm.
Anyway, but the point is that you have access from your EMR from home. So when you are preparing, actually, that is an opportunity when you're not in the stress of clinic, you can actually get even more familiar with your EMR and learn features that you otherwise would not know. And you would be surprised, you can learn some things that are like, oh, wow, this is really cool. And then you then incorporate that into, you know, when you're doing clinic. You see what I mean? So yes, EMRs, I think there are a lot of EMRs that are not that great, but we don't have a choice. Try not to get too caught up in it.
Mm-hmm.
Use your EMR as a tool to help you prepare for clinic and be efficient in clinic, okay? So let's do number 7. Techniques to build some factors include all of the following except some of these factors. So some of these factors up here: trusting relationship, diversity, all these things. Okay.
D.
D. Okay. Who said that? Muharram? Okay. Mohammed, what do you say?
I second that too.
D. Okay. Let's see. Create opportunities for interprofessional education. Absolutely.
Yeah.
Absolutely. Very, very important. Because when you're learning together, that improves, you know, that helps build trusting relationships, for example. Okay, B, expand skills in feedback, negotiation, and conflict resolution. Absolutely, very critical. This is truly a skill, okay? Many people in healthcare, for example, many people, like we go to medical school, right? We're very highly trained and all these things. Many people in healthcare are not like that. They are a medical assistant, but they could easily be a cashier in a grocery store. Okay, I was a cashier in a grocery store when I was a kid. So this is a job that what we call entry level. It is an entry level position, which means that, look, dude, you could be in high school and get this job. Okay.
Yeah.
So for these entry level positions, many people do not have the skills for conflict resolution and, you know, negotiation and feedback. You know, sometimes they don't know how to take feedback. Sometimes they don't know how to give feedback. If there's a conflict, they get frustrated easily because they don't know what is a good professional way to resolve conflict. Okay, so usually people need to increase their skills at conflict resolution. Okay, and so it's good for an organization to do that. C, practice leaders that model desired behavior. Very good. That's why for like, so I work as an administrator. I should not yell and scream. And I don't yell and scream, but you know what I should not do? I should also not get, as I mentioned before, not get agitated with things. Because sometimes I get agitated, to be honest. We need to be good role model, and we need to display how to resolve conflict, how to communicate effectively, and some stuff like that. Okay, so when you're and working in administration, I can assure you that the senior leaders, if they are good people and good models, then it filters down to the organization. Okay, I can assure you, if your leaders and directors and managers, if they scream and yell and they stress people out and they're not good role models, I can assure you the organization will suffer. No doubt about it. And then isolate and ignore behaviors that inhibit collaboration. Okay. So this person is always a jerk, just whatever, just let it be. Do you guys have stories about that? Any stories about that?
Not really. I mean, like when I was in the hospital, like some administrator will always try to like, be the peacemaker, try to create a mutual understanding. But yeah, I can see if administration or someone that was in charge had left, people getting agitated and yelling at each other, it would just harm the patient at the end of the day and not promote a good working environment.
Exactly. So we can see that that's obviously very bad for the culture of the organization. So basically, this is important. Let me just give you a story to illustrate D. One time I was on labor and delivery, okay? So one of the things I do is I deliver babies. That's the area within family medicine that I focus on as a clinician. So I one time there was a nurse, right? And she was being she wasn't being very helpful in my opinion. So what I did was like, I just said, look, this is what we're going to do. If you don't like it, I'm sorry, or something like that. It was a long time ago. I can't remember what I said exactly, but it was something like that. Okay. So what did she do? Now look, maybe her behavior was not appropriate, maybe, but my behavior was not appropriate either. Okay. And I was young and whatever. So what did she do? She complained to who? My boss. And what did my boss do? He talked to me about it. He said, Dr. Murad, I know you had this interaction. Can you tell me more about that? Okay, probably, shouldn't, you could probably maybe think of another way to do it and things like that. That's exactly what needs to happen. So if there is behavior that is not constructive, that does not promote teamwork, what I do at my organization now is I say that if there is something like that, guaranteed someone is having a conversation with you. Guaranteed someone will talk to you about it, because you cannot ignore these behaviors. Okay. If you're like, because to be honest, it's easier to ignore it. Okay. It is more difficult to have a conversation about it. Okay. It's hard. So it's much easier to be like, okay, well, they're not acting up now, so just whatever, just let it go. Just let it go. That is not something to let go. You need to not ignore it. Okay. So any questions on that? Okay. So a routine for conflict resolution. Yeah. And that's sort of at my organization what we say. We say, if any of these things are observed, we're just going to have a conversation with you. And that's it. It's just a conversation. And the more professional someone is, the better they take it. The more entry level that they are, they don't take it well. But that tells you something. That tells you that that's maybe not someone who's a good member of the team, possibly. And that's for the administrators to deal with, basically. Okay. And so every organization should have some sort of approach to conflict management. And that's part of a good culture. Okay. All right. And then we talked about EMR. You decide, oh, by the way, an EMR, anytime an organization decides to implement a new EMR, just get ready, buckle up. It's not going to be easy. So you decide that it's time to implement a new electronic medical record in your practice. Reasonable expectations of what a working system will bring to your practice include what? What do you remember? The EMR, it is a tool. It is a tool for you to use to do your work, okay? So you do your work. Your EMR, you need to use it as your tool. So what's the answer here? What do you think?
This was the one that I had, there's only one correct answer for this one?
Yeah.
Man.
Reasonable expectations that a working system will bring to your practice include which of the following?
A, B, C, they all seems to improve, but
yeah. Is it communication? Efficiency. Okay. Yeah, this was the one I was like, I don't know.
This is kind of interesting, isn't it?
Yeah.
Interesting. Yeah. So let's Now I feel like I'm the teacher looking at the answers here. Let me see what I would pick.
Yeah.
Reasonable expectations of what a working system will bring to the practice include which of the following?
I don't,
Communication.
maybe office efficiency?
Include,
Or a
you know what? I think this is, is this an accept? Hold on. Let me make sure this question is right. Reasonable expectations of what a working system will bring to the practice include which of the following? Very interesting.
Yeah, I was like,
Communication is likely to improve. Office efficiency is likely to improve. Patient care is likely to improve. Billing is likely to improve. Yeah, what would I pick? Because I agree. I think this is kind of a weird one.
reasonable, meaning like reasonable expectations. So it's like the bare minimum what this can do is probably communication. The end goal is for sure patient care.
It's very interesting. Yeah. You know what? If I had to pick one, C is usually a good one if you have to guess. So we talked about the longest one. You can pick C. And patient care, ultimately, that's the goal. So maybe I would pick C. But the answer is actually E. Let's see what's going on here. Maybe this is wrong. Maybe the book is
nothing will improve.
No. Let's see what's going on here. Implementation of an EMR is being promoted by many quality-oriented organizations as an important step towards safer and more effective healthcare for patients. Okay? Used properly under the correct conditions, it can add immensely to improvements in quality of care and efficiency of a practice. Okay? However, multiple studies have demonstrated that it is not the panacea many have proposed it to be. An EMR will not make a dysfunctional office functional. Careful attention to the underlying work relationships is more important to problem solving than implementing an EMR. Otherwise, what you will get is an office with the same old problems plus an EMR. So I think this is how we read the question.
I think, okay, yeah.
Yeah. So I think we were reading this question as what does an EMR do? Okay.
Yeah, we should go back to the main question.
Yeah. This is actually referring back to the thing here. Like what we're saying is that the office is having problems. There is difficulty with teamwork. There is difficulty with communication. That's the problem going on. So if that's the problem, then you're saying, okay, guys, we're going to do a new EMR. So in this office that's having problems, will the EMR, will it improve communication? Will it improve efficiency? Will it improve patient care or billing? And the answer is
no.
Yes, correct. So that's how we should have read the question. So and I think that this goes to saying that, again, the EMR is a tool for you to use. You have to have a good team, good workflows, good work routines. Like for me, I prep, and then before I start clinic, I huddle with my medical assistant to discuss what the clinic is going to be like that day. And I use the EMR as a tool to help me prepare. I use it as a tool to huddle with my medical assistant. We huddle together so my medical assistant can also be looking into the patient chart as we huddle for that morning. So we prep, we huddle, things like that. So again, it's a tool for you. It's not by itself going to improve and make things great if you're having problems. So that's how we should have read it. So, okay, good. All right, guys, I think that's it.
Okay. Well, Dr. Murad, I had a quick question.
Sure.
So as a family medicine doctor, you can also do like OB and deliver babies and stuff as well?
Oh yeah, definitely. Okay. I do. Yeah, so that's one of the fellowships.
Oh, it's a fellowship
available. Okay. In fact, that's where I did my fellowship at West Suburban Medical Center.
At West Suburban. Okay.
Yeah, I did my OB fellowship. So I finished my family medicine residency, and then I did an OB fellowship, and that's where we learn, higher risk OB, we learn how to, obviously a lot more experience doing vaginal deliveries, but we're trained in C-sections as well. And in fact, one of the things that I do now is I'm on faculty for an OB fellowship here in Kansas City, where we train family physicians how to do C-sections, how to do, complex OB and things like that. And by the way, this thing about team-based care, for me, I encounter it all the time with our backup OB-GYN specialists, okay?
Okay.
So when it comes to team-based care and talking to specialists, this is something that we do all the time, all the time.
And are you involved in like the whole OB care from like pregnancy till delivery?
Yeah.
Yeah.
Absolutely.
Okay.
Oh, absolutely. Nowadays, I'm doing more so personally, more so administration. So I've backed off like prenatal care. I still, I don't do that. Although I may do it again actually but anyway, I've backed off a lot of things. But to answer your question, absolutely. I mean, I have done thousands of prenatal care visits. I've delivered over 1,000 babies actually. Actually, wow. I think nowadays it's over 1,200 babies. Yeah, over 500 C-sections. Anyway, I mean, yeah. So this is my area of interest. In fact, there's a board certification for family medicine obstetrics. So, yeah. But it's not.
So it's a board. It's not through.
No, it's a board certification. It's not through the American Board of Medical Specialties. It's through the American Board of Physician Specialties. Well, whatever. Yeah, there's a board certification for that.
It's something. Yeah, absolutely.
Yeah. Awesome. So, but yeah, no, I love OB. I love it. But I also enjoy being a family physician as well, because as a family physician, I can do my stuff is so broad. But like in Europe, you know what they call something similar? They call it general practitioner with a special interest. GPSI, they call it gypsy, actually. I know because my brother-in-law used to practice in Europe. So he, I don't know, Mohammed, if that's the case, but they call it gypsy, general practitioner with special interest. That's something similar. So family medicine, of course, we talked about the difference between family medicine and GP in the United States.
Yeah.
But to be honest, GP in Europe is not GP in the United States. GP in Europe is like family medicine here, to be honest. But anyway, but I very much enjoy being a family physician, and then to have this area of interest, I find it very gratifying. So,
awesome.
All right, guys. So, well, I unfortunately got to go, but I really enjoyed our time together, and I'll go ahead and work on sending this for next week.
All right.
Okay. Sounds good.
Sounds
good. Thank you so much, Doctor.
So I would just say, in the meantime, here's what I would recommend as reading material. Let me just type it. What do you guys have as far as reading material for this, or for family medicine? What do you have as reading material?
Like blueprints?
Yeah, blueprints is good.
I use AFP.
AFP is very good. Yeah. Oh, by the way, Muhammad, I don't know did I share with you the AFP website?
I was already here. You shared the different resources.
Good. Okay. So my suggestion is, just to make it simple, whatever reading materials you have, please use those reading materials. Okay. I like where this comes from. This comes from Swanson's Family Medicine Review. This is where this comes from, this material. Okay. So that's the material that I'm using for this. Of course, we'll talk about it. It's not just answering the questions. We'll talk about really what does this stuff mean in practice. But I just think that's a good resource for family medicine. If you want to talk about additional resources that we use in family medicine, that's good reading material, I'll be happy to go through that. But this is like for board exam and just for general family medicine stuff. So so next week it'll be managing multiple morbidities. And what I will do is I will send this out for that topic so we can do the same thing next time.
Okay.
And so what I would recommend is just read as much as you can on this topic. You can go to You can go to the AAFP. I think that's very good. Whatever reading material you have on managing multiple morbidities, do that, and then we'll review the questions next time. So,
All right.
All right, guys. Well, thank you so much. I really appreciate it.
Thank you, Dr.
Thank you.
Thanks. Talk to you soon.
Have a great day.
See you next week. Bye.
See you next week.
Bye.